Hi everyone, good evening. So we'll continue with the radiology class. The last time we were discussing about how X-rays are being produced, how they are captured, and then how they can be viewed, right? And we saw about the techniques and the different types of X-rays starting from 2D to 3D, and also we were discussing a little bit about 3D imaging like CT, MRI, CVCT, and all that. So one other aspect of radiography that is very, very important when it comes to your head and neck imaging is pyelography. So basically, dentists don't study only about the teeth or teeth and the supporting structure, but we also have to know about the other vital structures like your salivary glands surrounding your maxillofacial region, right? So an important diagnostic tool for diagnosing the pathologies that are involving the salivary glands includes your xylography. So basically, in xylography, what we do is we try to take a radiograph, be it an occlusal radiograph or a skull radiograph, maybe. So for that, what we do is first we'll try to take a scout image. Scout image is like the image without injecting any contrast medium. So this scout image is the primary image that we do first. So after that, we will try to inject a contrast medium depending on the area which is affected. For example, if there is any pathology in the parotid gland, we will try to inject the contrast medium through the duct of the parotid gland, that is your Stenson's duct. Okay. Similarly, if there's any pathology involving a submandibular gland, we'll be injecting the contrast medium through the Wharton's duct of the submandibular gland. Okay, so we will be injecting the contrast medium through the duct of the particular gland which is affected to take another radiograph following the scout radiograph. So, depending on the image that is visible on the radiograph that is taken after injecting the contrast medium, we'll be able to diagnose the pathology. We'll see how. Okay. So, scout image is the blank image without any contrast medium. So, for injecting the contrast medium, we have three main phases. Okay. The first is the pre-operative phase, that is before injection of the contrast medium and the place where the scout image is being taken. Second is the filling phase, that is the phase where the injection medium is passing through the duct and where it's going to fill in the entire salivary gland that is involving the acini and the mini ductules also. Okay. And in the filling phase only, after the injection is completed, we will take another radiograph following that. And after this phase comes the emptying phase, where the contrast medium has to be removed. There's no necessity that it has to stay inside the body, right? It has to come out. So the emptying phase will be done. So the techniques how we can inject the contrast medium are simple injection, second is hydrostatic injection, and third is continuous infusion pressure monitored. So these are the ways in which your injection medium, the contrast medium, is injected through the duct of the salivary gland. So there are basically two types of contrast mediums that we use. One is an oil-based and the other one is the water-based. See, the pros and cons of each one is quite different. Okay, oil-based is slightly viscous, right? So which means since because of its viscosity, it has a very good contrast, which is an important advantage. Second thing is okay, second thing is because of the high viscosity, the slow excretion from the gland is there, which is actually cons only, but we have to take it in two ways. Okay, one thing is because of its high viscosity, it can be retained within the duct, so it can stay for quite some more time, so that the image can be taken slowly. If it is very watery, what will happen? It will just run through the duct, and then emptying phase will start take place very immediately, right? So, because of its high viscosity, there is going to be slow excretion from the gland. So it is both an advantage and a disadvantage of the oil-based medium. The main disadvantage is that because of the slow excretion, what is happening? There are chances for retention of the medium within the duct and the gland, which can lead to foreign body granuloma. Okay, foreign body granuloma reaction is not very common, but in cases where it stays retained within the gland without being completely emptied, in such cases, what will happen is there are chances of foreign body reactions. Okay. And on the contrary, this is about the oil based medium, right? On the contrary, when you look at the water based medium, it has a very low viscosity. So the emptying phase can be very quick. Again, this is an advantage and also a disadvantage. Okay. Because it gets emptied faster, we have to be very quick in taking the image after the injection of contrast medium. And second thing is, like I already mentioned, the aqueous medium is very watery, right? So because of that, what is happening? The contrast of the image is also compromised. Okay, so this is the disadvantage. Okay, and yeah, like since the excretion is very fast, yeah, advantage and disadvantages we saw. So these are the two types of contrast medium that are most commonly used. Okay, and here you can see the names of the contrast medium, the different types of contrast medium solutions that are most commonly used. Okay, and they are mostly iodine based, and they will include ionic aqueous solutions, non-ionic aqueous solutions, and the oil based ones. Okay, you can refer the names for your knowledge only. Mostly MCQs haven't come from this, but this is for your knowledge purpose only. Okay. Um, MCQs pertaining to xylography have been based on the appearances only. Okay, so they might ask you what is the xylographic appearance of your parotid gland or your submandibular gland. Like that, I think a few MCQs have been asked in the previous papers. So these are the key points that you have to keep in mind. So when you look at the normal parotid gland, the normal xylographic appearance of a good parotid gland will be a tree in winter appearance. Similarly, the normal xylographic appearance of your submandibular gland without any pathology is going to appear like a bush in winter. Okay, tree in winter means parotid gland. Bush in winter means submandibular gland. Okay, so this is how your duct, your small ductules, your acini, they'll all be completely filled with your contrast medium, and they will give this appearance. Okay, tree in winter, bush in winter. Try to imagine this. Okay, and based on the pathology, the appearances are going to change. When you compare Sjogren syndrome and sialadenitis, can you see the difference here? In case of Sjogren syndrome, you can see that the dots or blobs are seen outside the acini and the tubules. Okay, you can see the ejection of contrast medium outside the duct. But on sialadenitis, if you see, there is already inflammation of the duct, right? So duct and the salivary gland per se. So what is happening? It is entirely filled with the contrast medium and it looks very swollen. Okay, so this is the appearance of your Sjogren syndrome and your sialadenitis, comparing it with that of a normal gland. Okay. So certain characteristic features, like in case of any calculate, that is, in case of any sialolith, what will be there? There is going to be obstruction in the duct, right? So wherever there is obstruction, before that the contrast medium will be filled. I mean, the tube will be filled with the contrast medium, and there will be an obstruction beyond that. Wherever there is presence of sialolith, beyond that the contrast medium will not be able to pass through. Again, this depends on the size of the sialolith. Okay, if it is very small, again it will get washed away through the ingestion of contrast medium itself, and it will go and end near the final terminal end of the ductal arterioles are there. No, I mean ductules are there. No, it will go and end there. Okay, it will go and get obstructed in the smallest portion. So depending on the size of obstruction, that is depending on the size of the sialolith, that is going to be filling of the tube of the with the contrast medium. Okay, in case of sialodarcitis, I hope you're familiar with the term sialodarcitis. That is nothing but your inflammation of the ductal orifice of the salivary gland. Okay, so in case of sialodarcitis, the classic appearance that will be visible is your sausage link appearance. So whenever there is this dilatation and stricture, no, it's going to be continuous. Like imagine your peristalsis of your intestine, you know, right? The movement. So similarly, there's going to be dilatation, a small place where it's going to be stricture. Again dilatation, again stricture. So because of that, it is going to give a sausage link appearance. Okay. So this is the classic feature of your sialodarcitis. Next, sialadenitis I've already shown there, and Sjogren syndrome, we call it as punctate sialectasis or snowstorm appearance. Okay, punctate sialectasis or snowstorm appearance. And in case of intrinsic tumors like your mucoepidermoid carcinoma, your pleomorphic adenoma, you have so many salivary gland tumors, right? So in those tumors, the classic appearance is your ball in hand appearance. Okay, so these are the features of the pathology, salivary gland pathologies as seen in your silograph. Okay. Okay, so xylography is not only used for diagnostic purpose, but it can also have a interventional purpose. Okay, interventional as in case of xylolith, no presence of xylolith. So we can try to inject a cannula. You can see in the first picture, right? This cannula, it will be inserted through the duct into the area where it is obstructed, and then it will open up like a mesh. So this mesh is going to trap your xylolith and then pull it out. Okay, so this cannula will be inserted through the duct. It will open up like this meshwork pattern, and it is going to capture your silolith. Depending on the size of the obstruction, it is going to capture the silolith, and then you can pull it out. So this is your interventional silography. Okay. And apart from 2D, 3D, I also told you, right, there's 4D imaging. This 4D imaging, it is present in your USGs, and there is modified versions of your CT 4D imaging. I'm pretty not sure about it, but MRI has 4D MRIs are there. And yeah, like I already told, USG has 4D. So basically, the purpose of your 4D imaging is to capture for motion capture and all. In case of fetal imaging, we try to capture the fetal movements, right? When it comes to the head and neck region, we have our TMJ joint, that is a very mobile joint. So here we can observe the kinetics of the TMJ with the help of 4D imaging. So this is mostly used in prosthodontics and also wherever no patient is completely edentulous, when you have to simulate the jaw movements, no, for those purposes they'll be using. And in case of temporomandibular joint disorders, to locate where the problem is, to diagnose the pathology, obviously MRI is the gold standard for your articular disc and all articular disc pathologies and all that. But to find out if there is any pathology that is involving the dynamic movements of the TMJ, in such cases your 4D imaging will be useful for that. Okay. And yeah, moving on to interpretation. Now that you have seen there are so many types of radiographs and all, no, you have to know how to diagnose the radiograph, right? You should know what is normal, what is abnormal, how to diagnose it, and how it is being seen in each and every radiograph, how we name the structures in those radiographs. So basically, your IOPA, OPG, until the 2D images, no, we call them radiolucent and radio opaque, depending on the shade of gray. For example, if it is very black or if it is very dark, we call it as radiolucent because the X-rays have passed through, no, something like translucent, it is radiolucent, okay. Whenever there is obstruction of the X-rays because of dense bony structures or hard structures, no, similar to your opacity in the flow of light, we call it as radio opaque. Remember, okay? Radio opaque will be white in color. Radio lucent are those black areas. Okay. This is pertaining to your IOPA, your skull radiographs, your CEPH, your OPG, everything. Okay. When it comes to your higher level of imaging, that is your CT and all, we call them hyperdense, hypodense. Okay. Hyperdense is the brighter area. Hypodense is the lighter area. MRI, we call it as hyper intensity, hypo intensity. In case of your CBCT, also we use the same term like hyperdense and hypodense only. Okay, it's not radiolucent and radiopaque. We because we have to interpret the radiographs, right, for the doctors and all. They might be referring to you like for implant images or for any salivary gland pathologies or any head and neck pathologies. They'll be referring to you whenever you give the interpretation. These are the terminologies that you have to use. That is why we are knowing about this. Okay. And when it comes to USG, that is your ultrasonography, we call them hyperechoic and hypoechoic. Okay. And for the functional imaging, depending on the areas of affected areas, so depending on the pathology, we call it cold spots and the hot spots. See, mostly functional imaging is taken for ruling out the metastasis of cancers and all that. So whenever there is uptake of these contrast dyes by the tumor cells, those areas will be called as hot spots and cold spots. Okay. So this is pertaining to the functional imaging techniques, your SPECT, PET, and all that. Okay. So until now we saw about the diagnostic part, right? A little bit about interventional part or the therapeutic part. I can't say interventional; it's therapeutic part. Okay. So radiation therapy. So we use this high energy radiation from the X-rays to treat cancers. Okay. It can be used as the mainstay mode of treatment or also as a supportive mode of treatment. So there are many ways in which we can use radiotherapy for treating head and neck cancers as such. Okay. So for the indication in case of very smaller lesions, I hope you are familiar with the TNM imaging, right? So T1 and T2 lesions, the smaller size lesion, I think it's less than 2 centimeters. So in those smaller lesions, it can be used to completely excise the lesions in certain cases and also excise as in completely like only using radiotherapy, you can try to reduce, you can treat the smaller lesions. And in case of larger lesions or locally advanced lesions, also radiotherapy can be a mainstay mode of treatment, or it can be given following surgery. And we have different types of radiotherapy, like I already mentioned. Okay, so the three main things that we have to know is it's named as radical, adjuvant, and palliative. Okay, see, basically, radical radiotherapy means when it is used as the mainstay mode of treatment. Okay, in case of smaller lesions, radiotherapy alone will be more than sufficient for eradicating the tumor lesion. We need not go in for surgery or chemotherapy and all that. So radical means this one thing alone will be more than sufficient. Adjuvant means it is given following surgery. Okay, adjuvant is it is like a supportive treatment for surgical management. So it can be either given before or after. That is what they have mentioned here. It as pre-op and post-op, right? So pre-op means before surgery. So think logically. When will they give radiotherapy before surgery? Whenever there is large tumors, no, you cannot excise it completely, right? So in such cases, what they will do, they will give radiotherapy, shrink the size of the tumor, and then cut it off. That is pre-op radiotherapy. Post-op radiotherapy means after surgery, you have to remove the positive margins, right? There will be some kind of remnants. You can't say that 100% of the tissue has been removed. No, right? So obviously, to eradicate the positive margins, to remove all those areas which can be positive chances of recurrence of lesion. So those will be removed by post-op radiotherapy. Okay. So this is the two types of adjuvant radiotherapy. And palliative therapy is when no other therapy works out. Like this patient is not suitable for going for surgery or radiotherapy. Or, I mean, if the patient is not suitable for chemotherapy also. In such cases, palliative radiotherapy, it's just like a supportive treatment for the patient and nothing else can be done. So there is no success rate, but it's just to support the patient. And also, in certain cases, it has been shown that palliative therapy it doesn't allow the lesion to progress, but it stays the same. There is no worsening of the situation. That is what they mean to say. This is palliative radiotherapy. So these are the main important types of radiotherapy. Apart from that, based on the source of radiation, we can classify it as external radiotherapy and internal radiotherapy. As the name implies, external radiotherapy means we use an external source of beam, radiation beam, for giving radiotherapy to that particular affected region. Internal radiotherapy is when you use something like needles or pin kind of things for the intracavitary lesions. Intracavitary, as in, I mean to say, like regions like your tongue, your vaginal tumors, and all. No? Those are like cavitated lesions, right? So for those, you can inject the radiotherapy through a smaller source of medium, and it can be given internally. Okay, so in case of external radiotherapy, if you see, it is like en mass, right? It's covering most of the areas. So even your vital organs that are near to the area that is affected also will get affected because of radiotherapy. In case of internal radiotherapy, the chances of affecting the other vital surrounding structures is quite minimized. Okay. So I don't mean it's like the pros of internal radiotherapy, but comparatively, it is quite safer. But again, it depends on the area which is affected and the size of the lesion. Everything matters. So based on that only, you'll be deciding on what type of radiotherapy you're going to give. Whether you're going to use an external source or you're going to use an internal source. It totally differs, and it depends. It's all customized based on the pathology only. Okay. So these are the dosages that are most commonly used for giving those radiotherapy. For radical radiotherapy, it is 65 to 75 gray. For palliative, it is between 20 to 40 gray. And for adjuvant, it is between 45 to 60 gray. Okay, so these are the dosages. This also you should remember, obviously, for your MCQ part. Okay. So the mechanism of action of radiotherapy, if you see, no, it is more or less similar to the effect of radiation. I think you have it in the second chapter, no, biologic effects of radiation, direct effect, indirect effect. It is almost the same because the effect of X-rays on the human body, as in the harmful way, it's almost the same, right? Be it diagnostic or be it therapeutic, the way in which it is going to cause harm or cause any kind of destruction to the tissue is almost the same. Okay, so mechanism of action is the X-rays can cause damage to your DNA in two ways: direct method and indirect method. Direct method is directly go and hit on the DNA and it's going to damage it. Okay. In the indirect method, it uses water as an intermediary material. Okay, and there's going to be formation of free radicals, and then there is going to be destruction of your DNA. Okay, so this is the mechanism of action. Okay. So we need to know about the correlation between your cell cycle and when you have to give the radiation. Okay. There is a phase called as radiosensitive phase and radioresistant phase. Okay. Radiosensitive means this is the phase where the cells will be very much vulnerable to radiotherapy. Okay. So the tumor cell killing will be more in the radiosensitive phase. Okay, and in the radio-resistant phase, if you see, it is comparatively non-reactive because it is resistant to radiography. The reason why we call it as radio-sensitive is because it can respond to radiation. So more tumor cell killing is taking place. The phase that is radiosensitive is your G2 phase. The reason being, if you see in the cell cycle, first is your G0 phase, the resting phase, right? Then comes your G1 phase, then comes your S phase, synthesis phase, where your DNA is being synthesized. So in the G2 phase, if you see, before mitosis, the nucleus is there, no? The DNA of your, the nucleus of your cell, it is going to be very large because mitosis, that is reduction division, has not taken place yet. So the nucleus will be very big. When the target is very clear, what will happen? It is very easy to hit on it, right? So the nucleus is the target for your radiotherapy. So in the G2 phase, when the target nucleus is very much visible, very clearly visible, and it is larger in size, the X-rays can easily hit on it and cause higher level of tumor cell killing. Okay, high chances of tumor cell killing is there. So that is why your G2 phase is the radiosensitive phase. And once the G2 phase, for example, if the cell has crossed the G2 phase, what is happening? Mitosis phase will take place, right? Mitosis means reduction division, where your nucleus is going to divide to give produce your daughter cells and all that. So in the mitosis phase, it becomes radio resistant because the nucleus is broken down. I hope you're clear with this, right? So G2 phase is the radio sensitive phase, M phase is the radio resistant phase. Okay. So G2 phase, if you give radiotherapy, it is very, very favorable for more tumor cell killing and a reduction in the progression of the lesion. Okay. So they try to focus on this while giving radiotherapy. All right. So I think this was an MCQ that was asked once. So which is the most radiosensitive phase? That is your G2 phase. And we need to remember that M phase is the most radioresistant phase. Okay. So X-rays, whenever it is given in an optimal dose, it is good for reducing the tumor cells, and also, it is favorable for treating cancers like we already discussed. If it is given lesser than the optimal dosage, what will happen? There is going to be failure of damage of the tumor cell kill. Whenever it is given lesser than the optimal dose, it doesn't efficiently kill the tumor cells. Obviously, right? It's not going to be very much effective. When you give more than the optimal dose, what will happen? Apart from killing the tumor cells, it is also going to damage the surrounding vital structures and the other normal cells. Okay, so that is why the optimal dosage of radiation is very, very important. We saw, right, for radical therapy how much of dosage is important, and how much of grace for palliative therapy and all that. So whenever the optimal dose is not followed, there can be drawbacks or setbacks in the treatment, like failure to damage the tumor cells if it is given less, or it can damage the other normal cells if it is crossing the optimal dose. Okay. So if you look at the dose of your radiotherapy, there are certain factors that have to be considered when you're going to determine the dose of radiation. First is you have to look at the total treatment time that you're going to administer for the patient. Second thing is how many fractions you're going to give per day. Okay, because we obviously follow the fractionation therapy, right? So we have to see how many fractions we are going to give per day, and the type of radiation. Is it internal or external, or what kind of radiotherapy that we are going to administer? And the total dose of radiation has to be considered, and also dose per fraction of the dose per fraction of the treatment, that is also important. So these are the factors that involve or determine the dose of your radiotherapy. Okay, so why we have to fractionate, why we have to administer the entire dosage in fractions? For four main reasons. First thing is, when you fractionate and give, you're allowing the normal cells to recover. Like for example, you give three doses and then you give a break. Like you give radiation for 3 days in a week, and then you give a break. After that, again you give treatment for the next 2 days, and then again a break. So when you give it in fractions like that, what is happening? You're allowing the cell cycle to take place. So the normal cells will repopulate, and then it will grow and it will start to recover. And the cancer cells, like we saw, right, the cell cycle of the cancer cells, those who are dead will go off. But those who are repopulating, no, it has to come to the G2 phase, and then it'll be more radiosensitive, right? So you're allowing the normal cells to recover. Also, apart from that, what you're doing is you're allowing the tumor cells to move from the radio-resistant phase to the radiosensitive phase. So that also is taking place. Third thing is you're improving the patient tolerance. See, continuously you're giving radiotherapy means already there are certain drawbacks or setbacks because of that in the patient's health, right? So if you give a break in that, if you fractionate the dosage and give, it definitely improves the patient tolerance towards the treatment. And apart from that, the chronically hypoxic tumor cells. Okay, the we know that once we give radiotherapy and all, we are trying to hypoxia. I mean, that we are going to create a hypoxic environment in the tumor, right? So this will also reoxygenate the cells in those tumors will start to reoxygenate, so it will better respond to radiotherapy. Okay, so these are the advantages of fractionation over the single dose method. Fractionation is also called as multi-dose method. Okay, okay. These are the 5 R's of fractionation that you have to remember. Whatever we saw in the previous slide, it's like a gist only. Okay. So repair, repopulation, reoxygenation, reassortment, intrinsic sensitivity. Okay. So if they ask what are the 5 R's of fractionation, these are the things that you have to remember. Okay. Repair, repopulation, reoxygenation, reassortment, and intrinsic radiosensitivity. Okay. So based on fractionation, these are the different types of radiotherapy that have been followed. A conventional split course therapy, hyperfractionation, accelerated fractionation, and so on. Okay, so these are the different types of radiotherapy based on fractionation. Okay, and if you want, you can take a screenshot of it. These are the different dosages and the fractionation periods that have been followed. Okay, in conventional, you can see, right, 1.8 to 2.2 grays are given per day, and they are given for 5 days in a week for a period of 5 to 7 days. And for hyperfractionation, 1.15 gray twice a day for 5 days, and 5 days per week for 7 weeks. Okay, and in case of accelerated fractionation, it is 1.6 grays thrice a day for 5 days in a week for period of 5 weeks. Okay, so this is the total duration. Okay, and this is in per week, and this is a number of doses in a day. Okay, and for chart, I think it has expansion concomitant radiotherapy. Okay, so in this, if you see, 1.5 grays are given thrice a day for 7 days in a week for a period of 12 days. Okay, so these are the different types of radiation that have been used, different types of fractionation therapy, where radiotherapy can be administered for treating cancers. Yep. When it comes to the internal radiotherapy, it is also called as brachytherapy. Okay, so there are 3 types in which it can be administered. First is the intracavitary or luminal, second is interstitial, and third is surface mold. Okay, see these are the 3 techniques in which your brachytherapy or your internal radiotherapy can be administered for the patient. Yeah, like I already mentioned, your X-rays are like a double-edged sword. It is definitely advantageous, like a diagnostic and interventional treatments and all that. On the other hand, definitely it has certain side effects on the human body. It can cause a certain level of damage to the human body. So these again the same thing. Your how your X-rays are going to damage your DNA. So the DNA changes that take place because of excess radiotherapy are breakage of one or both the strands. See, I think one MCQ was asked initially, like which is more harmful, breakage of one strand or breakage of both the strands? See, breakage of both the strands is definitely lethal to that particular cell, because if only one strand is damaged, the other one will act as a template and it will again help in the formation of DNA or DNA complex. Okay, but if both the strands are damaged, definitely it's not going to recover at all. It is completely irreversible. So the DNA changes, it leads to breakage of one or both the strands of the double-stranded DNA. Cross-linking of the DNA strands can take place. Change or loss of the base, that is the purines and pyrimidines are there. No, so the change or loss of the base of the DNA can happen, and disruption of the hydrogen bonds. These are the hydrogen bonds, right? The hydrogen bonds between the base pairs. This can be disrupted because of the effect of X-rays. Okay, so these are the 4 main changes that takes place in the DNA because of increased dose of radiation. Okay, and these are the 2 main effects that take place in the human body because of high levels of radiation. One is your deterministic effect and stochastic effect. So I hope you all be familiar with this. The main key point that we have to remember here is, in your deterministic effect, it is like proportional to the dose of radiation. Okay, so you can see here, right, the severity of the effect is proportional to the dose. Whenever the dose is high, again the effect also is going to be high. On the other hand, your stochastic effect is like an all or none law. either there's going to be some kind of damage or nothing is going to happen at all. And in most of the cases, this is going to be sublethal damage of DNA will be present, and here it is going to cause heritable effects and radiation induced type of cancers will be seen. And stochastic effect is not dose dependent, it is independent of the dose of radiation. Okay, so this is about your deterministic and your stochastic effects. Please know about the examples also. I think that can be asked in MCQ for you. Okay. So the radio sensitivity of cells depends on, they have given four options for you: mitotic future, mitotic activity, degree of differentiation, all of the above. Radio sensitivity, oh sorry, all of the above, none of the above has been given. See, whenever all of the above is given, please blindfoldly don't try to go for all of the above. Sometimes there can be a catch in the question. So in this particular question, obviously your radio sensitivity is going to depend on the mitotic future, your mitotic activity, and the degree of differentiation. So that is why the answer is all of the above. Okay. Okay, so relative radiosensitivity of various cells. See, these tables are important for your MCQ because they might give you some kind of like four categories. They might give you like for example they'll give you basal cells of oral mucous membrane, less than vascular endothelial cells, less than neurons. So they might ask you to rate the hierarchy of radiosensitivity in these three cells. Okay, in these three cells. Okay, so you must be knowing which is more radiosensitive, which is more less radiosensitive, and all that. Okay, so you can try to take a screenshot of the table, or if at all it's given in your this thing. What's that? White and Farrow textbook. So you should know which is more radiosensitive, which is less radiosensitive. More radiosensitive is going to include your spermatogenic and your erythroblastic stem cells and your basal cells of mucous membrane. And the least radiosensitive cells include your neurons, your muscle cells, your squamous epithelial cells, and your erythrocytes. And these things come under the intermediate category: vascular endothelial, your fibroblasts, acinar and the ductal salivary glands, and your parenchymal cells of liver, kidney, and thyroid. So these come under the intermediate category. Okay, so this is the relative radiosensitivity of different types of cells. Moving on to the organs. Since we saw about the cells, we should also be familiar with the organs, right? So the most radiosensitive organs include your lymphoid organs, your bone marrow, your testes, intestines, and the mucous membranes. And in case of the least ones, it is going to include your optic lens and your muscle. Okay, and the intermediary ones in this category comes your fine vasculature, your growing cartilage, your growing bone, salivary glands, your lungs, kidney, and liver. Okay, so anything of it can be an MCQ. Yeah, similar to this. The most radiosensitive of the cell, the most radiosensitive of the following cells in terms of cell killing. We have given you four options: cardiomyocyte, basal epithelial cell, endothelial cell, neuron, and polymorphonuclear leukocyte. Okay. So, if you see amongst this, your basal epithelial cell is most mitotically active, and it is the most radiosensitive one when compared to the others. Neurons will come under the low radio sensitive. Okay, and endothelial cell also will come under that only. Only this, I think, it comes under basal epithelial will come under the high or the most radio sensitive category. Okay. So these are the side effects that take place because of radiotherapy. Okay. So you can see there's going to be presence of taste loss, mucositis or stomatitis will take place, hyposalivation of xerostomia in certain cases, radiation caries, trismus, and susceptibility to osteoradionecrosis. You can see, right, there are on this chart, you can see that this indicates the dosages of your radiation, and this indicates the duration of therapy. You can see the timeline, right, which occurs first and which is reversible and which is not reversible. See, your radiation carries hyposalivation, trismus, and osteoradionecrosis and all. They are mostly irreversible and they take a very long time for, for, I mean, if you don't treat it at the early stages, obviously it's not going to revert back at all. There's no way that you can reverse your osteoradionecrosis and all. And radiation carries, obviously, if you see the treatment, it is going to be only tertiary, that is rehabilitation of the lost tissue only will be the mode of treatment, right? So these are irreversible. On the other hand, if you see your taste loss and your mucositis and all, it is present in the patient for a brief period of time, and after that, it is going to be reverted back to normal. And this one is like a sequelae, okay? Your hyposalivation and radiation caries, if you see, no, the reason why you get radiation caries is because of hyposalivation only. Because the salivary glands are exposed to high amounts of radiation, the acina cells will start shrinking and they will produce or release very less amount of salivary secretions. Okay, so because of that, it is going to already there is mucositis and stomatitis for the patient, right? So increased burning sensation and all are going to be there. And because of hyposalivation, the saliva production is less, no? So because of that, the washing away of the food particles or the remnants of the oral cavity is not there. You know, right? Your saliva is the good source of a lot of bacteria, and it's also helps in the cleansing activity of your oral cavity and also lubricates your oral mucous membranes. So all these things are going to be stagnated because of radiotherapy. And because of hypersalivation, like I already mentioned, your food particles are not going to be washed away very easily. It's going to stay on the teeth. And because of it only, as a sequelae of hyposalivation, your radiation caries will start to occur. Okay. Yep. So there's one condition that we have to know about when it comes to your side effects of radiation, that is your acute radiation syndrome. Okay. So it's nothing but a collection of signs and symptoms that a patient will experience after the whole body is exposed to radiation. Okay. So when you look at the acute radiation syndrome, depending on the different dosages, okay, there is the patient is going to manifest with different types of symptoms. And you can see that the patient responds in four main stages. First is the prodromal stage, second is the latent period, third is manifestation of illness, and the last one, if the patient is treated on time, then there are chances of recovery, and if left untreated, it can be lethal to the patient. Okay. So, with the dosage of 1 to 2 gray, patient is going to manifest with the prodromal symptoms like fever, malaise, and all that. Okay, and 2 to 4, you see mild hematopoietic symptoms like anemia, and in certain cases, there's going to be a decrease in the levels of your clotting factors and all that. Okay, so in case of 4 to 7 gray, there's going to be severe hematopoietic symptoms. Okay, so apart from reduction in your RBCs and your platelets and all that, there's going to be a definitive reduction in your WBCs also, because of which patient is more susceptible to any kind of infections. Okay, and when the dosage is even more increased to 7 to 15 gray, patient will manifest with gastrointestinal symptoms like ulcers and all that. Okay, and when it crosses over 50 gray, what happens is your CNS and your CVS will be affected. Okay, so cardiovascular system is getting affected and your brain, which leads to dementia, disorientation, and all that. Okay, so these are the symptoms of your acute radiation syndrome and the dosage at which the manifestation of symptoms will occur. Okay. So when you look at the lab tests, they have to be performed once in every 6 hours. A complete blood count and differential count has to be taken, and the genetic material will also be examined within the first 24 hours to see if there is any presence of chromosomal damage. When you look at the management, it depends on the stage of which the patient has been affected and the system that has been affected, depending on the dosage of gray, and then only we'll treat the patient accordingly. Okay. Yeah. Susceptibility of the different organs to radiation induced cancer. See, radiation induced cancer means you have to think about stochastic effect. Okay, so these are the more susceptible ones, like your colon, stomach, lung, your bone marrow, and your female breast. And the least ones include your bone surface, your brain, salivary glands, and your skin. The intermediary ones include your bladder, liver, and thyroid. Okay. So, what is the average dose for the dental professionals who are occupationally exposed to radiation? They've given you four options: zero point 0.2 millisievert, zero point 0.4 millisievert, 10 millisievert, and 40 millisievert. I think it's between zero point 0.2 to zero point 0.4. Yeah. The average dose of the dental professionals who are occupationally exposed to radiation is about zero point 0.2 to zero point 0.4 millisieverts. Okay. So, according to the National and the International Commission of Radiation Protection, you can see, right? They have given you like guidelines how much of dosage is acceptable when it is present in the occupational as in the dental professionals and the radiographic professionals. Non-occupational includes the patients. Okay. So the allowable dose of radiation to be present when the occupational personnel is being tested is 50 millisieverts annually and 10 millisieverts in a year. So if you see more than the diagnostic aspect, no, the therapeutic radiotherapy, the dosage is very much higher, right? So those radiographic professionals who are working in providing radiotherapy, they are more susceptible to any kind of cell damage when compared to the diagnostic personnel. Okay, so these are the guidelines for your national and international radiation protection. So the optimal dose limit for your structures and your the maximum permissible dose per year has been mentioned here. So RAM is radiation units. It is like a radiation unit that I will be telling you in some time. Okay. Yeah. So the ways in which your radiation exposure can be decreased are by the usage of F-speed films. This one we already studied, right? And the usage of intensifying screens in case of extraoral radiographs. Then use of collimators. In case of your radiotherapy also, no, this machine has the usage of multi-leaf collimators. So these multi-leaf collimator will tend to reduce the dose of reduce the low dose radiation, and also it tends to prevent the other surrounding vital structures from being radiated. And then your filtration, obviously, and your lead aprons, your thyroid collars, increasing the focal spot to full distance and increasing the KVP and the optimal optimal exposure time. So these are the ways in which the radiation exposure can be reduced for the patient. Okay. Okay. So when it comes to radiation safety and protection, the principle that is most commonly involved is your ALARA principle, as low as reasonably achievable. And the usage of your thyroid collars and your lead aprons are alternatives to reduce the radiation exposure. Thyroid collars and if you see the lead aprons and all, no, it is present for both the personal and also for the patient. So both of them can be protected from harmful radiation. Okay. So radiographs of a pregnant patient should never be made, should be made only in the third trimester, should be made with a triple leaded apron, should be made only when that's a specific need. See, we all know that the second phase of pregnancy is the most favorable one and the most safest period. But we cannot consider radiation in any phase of therapy. That is my personal advice. So the ideal answer for this question is it should be made only when there is a specific need. And the most ideal radiograph for pregnant women includes your CBCT or your IUPA radiographs. IUPA, the radiation is very, very minimal and it is mostly negligible. Okay. Even in IUPA, if you see in the digital radiographs, your CCD and CMOS and all, they are even more effective in controlling the radiation than compared to your conventional radiographs. Apart from that, CBCT is like only if it is really necessary. Patient is having some kind of expansile lesion, you suspect some kind of pathologies there. Only when there is a need will you go in for a CBCT. And CBCT also, instead of going for CT and all that, you can go in for a CBCT and observe the lesion. Or in most cases, what we advise is we ask the patient to wait. If it is not an emergency, we ask the patient to wait. Once the pregnancy period is over, and only after the labor, we'll try to go in for X-rays. Okay. Answer for this question is option B. Okay, so what is the threshold dose of radiation for a from a full mouth radiograph when lead apron is used? So, full mouth radiograph, we all know, right? The entire mouth is going to be taken for radiotherapy. So, sorry, excuse me. So, whenever the full mouth radiography is being taken, the threshold dose of radiation should be 0.25 milligrays. Okay. So when it comes to the personal protection, we need to have a device to measure the amount of radiation that we have been exposed to, right? So for that only we use this dosimeter. This dosimeter will monitor the exposure of the person to the radiation dose, and then it will give you a value. Okay, so basically it is available in this form only. Okay, we call it as thermoluminescent badges or TLD badges. This one you will be commonly seeing in case of your radiology department. It is available in the form of watches or badge or in the form of rings also. Okay, so this one, what will happen? It will have a plate here, right? So as and when radiation has been given to it, it will be storing the amount of radiation that is being exposed to. And once in 3 months, what we do is we give it to the lab for testing. So they will be inserting it into a machine, and depending on the dose of radiation, it will be illuminated and it will give a reading in the spectrometer. It can be read using a spectrometer. Okay. So based on the level of illuminescence, a value will be given, and this should be remaining within the optimal dose of radiation. It should not go beyond that. If it is going beyond that, then it means the patient is exposed to higher level of radiation, and they will be given a break for a while. In case of radiotherapy and all, no, people who are working there, they will be going in rotations, and they will be given a break if the dosage in their bodies absorbed to a higher level. They'll be given a break for a short period of time, and then after that, once the cells they recover and everything, again after that only they will start working. Okay, so this is the purpose of dosimetry. Okay, so in dosimetry, if you see, we have certain terminologies that we need to remember. First is exposure. Exposure means it measures the amount of radiation that has been administered. Okay, and absorbed dose means it measures the ionizing radiation absorbed per unit mass of the body. Then comes your equivalent dose. Equivalent dose is to compare the biologic effects of radiation between different types of tissues. Okay, an effective dose means it is like a summary, okay, summing up of the equivalent doses weighted by radiosensitivity of an exposed tissue or organ. And then comes your radioactivity. This describes the decay rate of the sample of the radioactive material. So, as you can see, these are the different types of quantity for measuring dosimetry. These are the definition, and these are the traditionally used units and the recent SI units. Okay, so exposure is measured in coulombs per kg, absorbed dose is measured in grays, equivalent dose is measured in sieverts, and effective dose is measured in sieverts again, and radioactivity is measured in becquerel. Initially, it was named as Curie by the person who discovered radioactivity, Madame Curie, and later on it had this SI unit of becquerel. Okay, so this is about dosimetry. And when it comes to quality assurance and infection control, no, these are the things that you have to be scheduling to maintain the quality of your radiographs. Okay, like you have to do certain chores on a daily basis, on a weekly basis, monthly basis, and yearly basis. And this is to maintain the quality of your radiograph and also to prevent the infection progression. Okay. So when it comes to interpretation, I would always want you to remember these 5 steps. Where it is going to help you is in case of picture-based questions. Now they can give you X-rays, images of any kind of lesions, and they will ask you to find out which is which. Okay. So in such cases, I want you to look in this following aspect only. Okay. You have a radiograph in your hand, and for interpreting it, first thing that you should see is the localizing the abnormality. Okay, first thing is localizing the abnormality. Second thing is identifying the position. Third, analyzing the shape of the lesion and the periphery of the lesion. Fourth one is analyzing the internal structure of the lesion. Fifth one, effect on the surrounding structures. Okay, so 5 main things: localize the abnormality, identify the position, analyze the shape and the periphery, analyze the internal structure, effect of the lesion on the surrounding structures. So these are the 5 main steps in interpretation. Okay. First thing is localizing the abnormality. Localizing the abnormality as in if it is present in the maxilla or mandible, or it is present in both. If it is present on one side, that is unilateral or bilateral, where it is being present, if it is crossing the midline or not, generalized lesion or localized lesion. So these are the things that we mean to say for localizing the abnormality. Okay, because each one is individual. Okay, for example, if you see no certain type of lesions, they will be limited only to the mandible. For example, like your dentigerous cyst and all that, no, and your ameloblastoma, they are mostly confined to the posterior part of your mandible. And this crossing the midline and within the midline, no, mostly OKC has a tendency to cross the midline to the opposite side because OKC is a kind of antro-posteriorly spreading lesion and it is not a bilateral lesion. Your cystic lesions, your most of the jaw lesions are bilateral. There can be bicortical expansion that is taking place, whereas your OKC has an anteroposterior expansion of lesion. Okay, so it has chances to cross the midline and go to the opposite side. Okay, so this is about localizing the abnormality. Yep. Second thing is identifying the position. So what do I mean to by saying? What do we mean by saying identifying the position? So we have to see whether it is located within the soft tissue or the hard tissue. Okay. So if it is well defined or not, and certain lesions, like I already told, no, certain lesions are specific to certain areas. For example, your CGCT cells mentioned here, central giant cell granuloma. So this one it occurs anterior to the first molars in the mandible and anterior to the cuspids in the maxilla. So again, if you see in this, no, your central giant cell granuloma is present within the bone, but your peripheral giant cell granuloma is a soft tissue lesion. So depending on the position, we can classify the lesions again. Okay. So this is again an important tool for helping in interpretation. All right. So whenever you see epicenter means it is the starting point or it is the main point of the lesion. So whenever the epicenter of the lesion is coronal to the tooth, mostly it will be odontogenic. If it is apical to the tooth, if it is involving the tooth, then we can suspect it to be odontogenic. If it is not in contact with the tooth, we can also think of it as a non-odontogenic lesion. Okay, and whenever the epicenter is above the inferior alveolar canal, in most of the cases, they are odontogenic, and whenever it is below the inferior alveolar nerve canal, it becomes non-odontogenic. Okay, so these are like hints, okay, for coming to the final diagnosis. So you're seeing a lesion, you have a cystic lesion that is surrounding the tooth, but it is present in the apical region. And if you see it is below the inferior alveolar nerve canal, not attached to the tooth, but it is below the inferior alveolar nerve canal means think of it as a non-odontogenic lesion. Then you have to list out what are the non-odontogenic lesions, what are the non-odontogenic cysts, and then only you have to rule out and come to the diagnosis. If it is being attached to the tooth, completely surrounding the tooth, you have to see if the tooth is having any pathology or if they have mentioned anything about the vitality of the tooth. Vitality also, by seeing the radiograph, you can say sometimes, like for example, it's like sure shot. It's not like a sure shot, but you can guess it. Okay, in case of areas where the pulp will be completely stenosed, no, because of atherosclerosis and all that. So whenever the pulp is completely shrunken, or in cases where there is pulp stones and there's going to be a blockage of the pulpal tissue, then most of the cases it is going to be like odontogenic lesion. It is going to involve the sequelae of your pathology involving the tooth. Okay, and on the other hand, if you've seen that the tooth is completely good, there is no visible decay, fracture, or if there's no clinical history pertaining to the tooth being affected, and based on the position of the lesion, you can diagnose it as non-odontogenic. Okay. Yep, this one I already mentioned, right? Epicenter below the inferior alveolar nerve canal, that is non-oncogenic. Whenever it is present within the neural canal, we call it as a neural lesion or a vascular lesion. The most important nerve in your mandible is your inferior alveolar nerve. Yeah, and it ends in the mental nerve and also incisive nerve. That also we should not forget. Okay, then moving on to epicenter within the sinus, mostly like any kind of sinus pathologies or your antral polyp, antral lip, anything. So when the epicenter is within the sinus, mostly it is going to be a sinus pathology. And epicenter in the maxillary alveolus. See the picture given here, it can either be a root stump, or that is a retained root stump, or it can be any kind of pathology, or it can be improper removal of your of your tooth, which remains like a remnant and it is completely occupied. And in certain cases it can also be like a paramolar or a distomolar, and if it is present in the anteriors we call it as mesiodens, right, or any kind of supernumerary tooth. So this is how you identify the lesion based on the epicenter. Next thing, the third point is analyzing the periphery, right? So we have to see if the periphery of the lesion is well defined or ill defined. That is also again important. In case of cystic lesions, so we call it as corticated margins, okay? And in case of fibroosseous lesions or those that have a mixed radiolucent radiopacity and all that, mostly it appears sclerotic in nature, okay? So this is about analyzing the periphery of the lesion. Okay, so well-defined lesions, if you see, no, there are certain categories that we have to remember. Punched out borders, and second one is corticated borders. Okay, punched out border, corticated border. Mostly the punched out borders are seen in case of thalassemia and all that, and corticated borders are mostly involving cysts. Okay, cystic lesions. And sclerotic margin mostly is in case of fibroosseous lesions, and soft tissue capsule is in certain cases, no, the radio opaque structure that is either seen in the periapical region or adjacent to the tooth structure. The radio opaque structure will be surrounded by a radiolucent halo. This is nothing but a soft tissue capsule. Okay. Moving on to the next one. In case of malignant lesions, no, there is going to be presence of ill-defined invasive borders. Okay, so there's going to be more destruction of the adjacent structures. So it's going to leave invasive borders, and there's also going to be your finger-like projections, as in your cancer cells will creep into the other vital structures, and it is going to damage that also. Okay. Analyzing the shape. Based on the shape of the lesion, if it is very much circular and well defined and all that, we can think of a cystic lesion. If it is scalloped, okay, scalloping means there are multiple locules that are attached to each other by small septae in between. Okay, so the scalloping of the lesion is most characteristic presence of your OKC, your odontogenic keratocyst. It is a scalloped lesion. Okay, so because of the multiple locules and the septate in between, it is giving appearance like a scalloping. Okay. So moving on, now we saw about the periphery and the shape and all that, right? We have to go inside now. Based on the internal structure, you can see the hierarchy, right? The most radiolucent to the most radio opaque. This is the hierarchy of the lesions to analyze the internal structure, because it can be a cystic lesion or anything, right? It can be either filled with water, or it can be filled with pus if it is infected, or it can be filled with the blood or gas or anything. So depending on the most radiolucent, that is your air and the fat, going down to the most radio opaque, that is your enamel and your metal. Okay. So this is about analysis of your internal structure of the lesion. Okay. So it can be completely radiolucent, completely radio opaque, or mixed radiolucent, radio opaque. So based on this, we can give several differential diagnoses. Okay. So analyzing the internal structure, in case of multilocular lesions, now we saw about OKC, right? I told you there'll be multiple locules and septae in between. So depending on the shape of the multilocular lesions, we can try to identify the pathology. For example, your honeycomb appearance and your soap bubble appearance. These are classic features of your ameloblastoma. See, but there is an structure, I mean, the structural difference between your honeycomb and soap bubble is, in case of honeycomb pattern, no, all the locules will be more or less same in size. Okay, they'll be like, it'll all be uniform in size. Okay, whereas on the other hand, if you see your soap bubble appearance, it is not uniform in size, but one lobule will be big, one will be small, and one will be medium size. So it's almost the same, like your honeycomb and your soap bubble. It is seen in case of your ameloblastoma and everything only, but depending on the size of the lesion and how it is being presented. Okay, so the diagnosis can be shortlisted. So whenever you see a multilocular lesion in your radiograph, you have to go think about the differential diagnosis. Observe the pattern of your, see whether it is unicystic or multicystic first. And in case of multilocular lesions, observe the septal pattern. Okay, so if the septae are almost equal in size and all the locules are smaller in size and almost same, then we call it as a honeycomb pattern. If it is larger in size with different shapes and sizes of your globules, then we call it as a soap bubble appearance. Both are characteristic appearances of your ameloblastoma. Okay. Moving on to the next thing. Yeah. So this thing, no? Again, these are multilocular lesions only. Tennis racket appearance, we call it because the septae will be exactly at right angles to each other. Okay, so they'll be perpendicular to each other. That is why we call it as a tennis racket appearance. And scalloping lesion, we already saw it in case of an OKC. We have a scalloping lesion. Okay. So radio opaque and radiolucent, if you see, these are the different types of radiation radiographic appearances that we have to remember. Ground glass appearance we see in case of fibrous dysplasia, and you can see the presence of new bone formation, right? And septations within the bone, most likely to be a dentigerous cyst or an ameloblastoma. You can see that even the lower margin of your mandible, that is the inferior border of mandible, has been very much thinned out, right? So the chances of fracture is very common when it comes to different types of your lesions. Okay. Amorphous presence of amorphous bone or tooth structure within like dense and dente, or in case of any impacted supernumerary tooth. And then comes your dystrophic calcifications. So this is what I actually tried to say. You can see that the pulp chamber has been obstructed, right? So because of that, you can say that even the lesion is trying to have in some kind of loss of vascularity, right? So because of dystrophic calcification, the pulp chamber has been completely obstructed, and there is going to be decreased blood supply to the tooth, because of which the tooth can turn non-vital. Okay, so these are the different types of radio opaque lesions. Okay. Moving on to patterns of destructive bone lesion. This mostly is applicable for cancerous lesions, where you can observe a geographic pattern with large number of lyses, no expansion, and benign or malignant lesions are most commonly involved in this category. Then comes your moth-eaten appearance, which shows several smaller areas of lysis with no kind of cortical expansion. And in case of permeative pattern, area of rapid destruction will be seen. Okay, that is your cancer cells will start to penetrate the other surrounding vital structures. But the expansion of the cortex, that is the bicortical expansion, is not very much visible. Okay. Moving on to expansion of the cortical plate. So, like I already told you, we have two cortical plates, right? The buccal cortical plate and the lingual cortical plate. So, the expansion of cortical plate comes in two ways: localized or bicortical. Okay, localized or cystic or unilateral, and benign tumors, which is mostly bicortical. Okay. I think it's unicortical. It's not unilateral, but can be unicortical. And in most of the cases, if you see, in case of mandibular lesions, your buccal cortical plate will be mostly expansile. Okay, rather than the lingual aspect, the buccal aspect is mostly expansile, and I would say that is even more safe also, because if the lingual cortex is expanded, and in certain case, sometimes it can try to be reactive, and because of that, what is happening? Whenever even there is the smallest of the damage to the lingual cortical plate, it is going to involve your pharyngeal airspace and all that. So it's quite harmful to the patient. Okay, so this is about the expansion of the cortical plates. Moving on to the destruction. Destruction I've already discussed with your friend. Okay, so this is the destruction of cortical plates because of high expansile tumors and aggressive tumors are there, no, like your OKC and all that. So it is going to erode your bone completely. There's going to be rapid destruction of both the buccal and the lingual cortical plates. Okay. Then comes the effect on the surrounding structures. So when you look at the effect on surrounding structures, no, basically what is happening is you have your apart from your bones, what are there? Your teeth is there, your sinus is there, your TMJ is there. So these are going to cause effect on the surrounding structures. Okay. So in certain cases, what is happening whenever the lesion is completely destructing the adjacent structures, there can be resorption of the roots. There can be displacement of the teeth. Your neural structures there, no, your inferior alveolar nerve canal and all that. They can be displaced, or there can be even destruction of your neural canals also. In worst cases, what will happen is, apart from destruction of your inferior alveolar canal, also the inferior border of the mandible can be destroyed, which can lead to pathologic fractures. So all these things will come under effect on the surrounding structures only. Okay, excuse me. Okay, and apart from this, now we can also observe certain changes like widening of the pedial space. This can be either localized or generalized. Okay, in case of smaller odontogenic lesions, there will be localized widening of pedial space, and in case of systemic lesions, no, you'll be able to observe generalized widening of pedial space. You have to correlate it. Okay, localized means you have to see whether there is any pathology in that particular area. But if you see continuous widening of pedial space in almost all the teeth, then you have to think about systemic lesions also. That is systemic correlation also. Apart from the pedial space, no, your lamina dura, that is also a kind of diagnostic entity only. So the changes in lamina dura, like if you see, no, your lamina dura has to be continuous, right? Whenever there is interruption, whether it's localized or generalized interruption. So based on that, we'll be able to diagnose the lesion also. Okay. Yeah, that is what I was mentioning. Loss of lamina, localized and generalized. All right. So apart from that, no, your bone also tends to react to pathology. So we call it as peripheral bone reaction. Okay, it shows different types of appearances based on the level of how much it is being affected. So these are the classic appearances of peripheral bone reactions. Onion skin appearance, we all know, right? It is like it is called as it is most commonly seen in case of your Gary's osteomyelitis, and your sunburst appearance is most commonly seen in case of your osteosarcoma. And yeah, like your periosteal bone reactions take place because of four main reasons: because of trauma, because of tumor, because of infection, and because of intake of any kind of drugs. Okay, so it is nothing but formation of a new bone because of an injury or any kind of pathology to the periosteum that is surrounding the intact bone layer. Okay, So new bone formation in response to injury or any kind of pathology to the stimuli that is reacting to the periosteum of the surrounding bone. Okay, so it reacts in two main types: non-aggressive and aggressive. Non-aggressive means it is like a thin, solid, thick, irregular, and septate patterns. Aggressive patterns are going to include your laminated, speculated, your sunburst, disorganized, and Codman's triangle. This is just for the namesake that you have to remember. Okay, MCQs, I don't think they've asked from this part, but they might give you the characteristic appearance, like in which lesion is Gary's osteomyelitis being observed, or in case of osteosarcoma, what type of peripheral bone reaction is seen. Like you should know that it is sunburst appearance. So these type of questions can be asked. Okay, but this one I'm pretty not sure. Okay. So depending on the morphological classification, again, there are different types. Okay. And then this one I already mentioned to you, right? The destruction or displacement of the vital structures. The one most important vital structure in your mandible is your inferior alveolar nerve canal. So there can be either displacement or destruction of the inferior alveolar nerve canal. Okay. Um, I think if you remember in the first day of the class, I told you I'll be giving you certain key points, right? This is basically for interpretation only. Um, Try to take screenshots or maybe take notes of it. I have given you the differential diagnosis of each of the characteristic appearance, okay? Whenever you see a periapical radiolucency, you have to correlate with any of this. So you see if there is any kind of pulpal pathology, and if it is coming as a sequelae of dental caries or anything like that, or observe if there is any kind of um, fracture of the lesion, or see if there's any kind of obstruction in the pulp chamber, like I already told. No, because of obstruction in the pulp chamber, sometimes the tooth can be non-vital, so results in pulpoperiapical pathology. Because of that, a periapical radiolucency can occur. So first observe the tooth. If it is present in the apex, no periapical radiolucency, first try to decide whether it is a odontogenic or a non-odontogenic lesion. If it is odontogenic, it should be any of this only: periapical periodontitis, abscess, granuloma, cyst only. Residual cyst is when the tooth has been removed. Okay. In case of an edentulous region, if you see a radiolucent structure, then we call it as a residual cyst. Periapical scar, no, it is mostly in case of odontogenic lesions, I mean endodontic treatments, no. Once a patient is having an abscess or a cyst and you've given endodontic therapy, and after healing also the radiolucency will still be persistent. So in such cases, we call it as a periapical scar. And surgical defects also. Okay, so these are the differential diagnosis for periapical radiolucencies. Then comes your pericoronal, that is surrounding the coronal portion of the tooth, most commonly impacted tooth. Okay, so without opacities, with opacities, you have different categories. So I have quoted a few examples for you. And then comes your multilocular radiolucencies. Multilocular, I've already discussed with you, right? We saw that the pattern of your septate, whether it is seen in soap bubble appearance, honeycomb appearance, or if it is perpendicular to each other, that is tennis racket appearance. See, tennis racket appearance is classic feature of odontogenic myxoma. You need not get confused. Between soap bubble and honeycomb, I told you the morphological differentiation, but if you see the diagnosis, no, honeycomb and soap bubble both are seen in case of ameloblastoma. Okay, so depending on that pattern, we have to diagnose it. Okay, and in case of central giant cell granuloma, we call it as a wispy pattern. Okay, so try to remember that also. So these are the differential diagnosis of your multilocular radiolucencies. It can be either ameloblastoma or odontogenic myxoma. Now you know how to differentiate. An aneurysmal bone cyst, mostly it will not be involving any tooth and all, right? So central hemangioma also, it need not necessarily involve any kind of teeth. So these two again, it will be non-odontogenic only. And cherubism, if you see, it will be entirely like bilaterally, it will be visible, and the age of the patient will be less. Okay, it's more common in children only. So that is cherubism. And hyperparathyroidism, again, it is like a systemic disease. So they might give you a clue pertaining to hyperparathyroidism. In the question itself, they would have given you a clue. Okay, and then OKC. OKC, you have to observe if the lesion is crossing the midline or not, and the scalloping borders. So this one is the characteristic feature of diagnosing your OKC. Okay, so poorly defined radiolucency is again another category where you have a certain differential diagnosis, and then generalized rarefactions like your osteoporosis. Rarefactions, as in they are mostly like mixed lesions only. Okay, your rickets, osteomalacia, hyperphosphatasia, sickle cell anemia, thalassemia, and all that. These come under the category of generalized rarefactions. Okay, and then oh sorry, excuse me, periapical radioopacity. We saw about periapical radiolucency, right? This is periapical radioopacity. So it can be either solitary or multiple. So these are the differential diagnosis for it. See, for reading your differential diagnosis, apart from your white and farrow, you have a textbook called as Wooden Ghost. Okay, so this Wooden Ghost, no, it has small tables. Okay, um, in each of the chapter. For example, if you consider periapical radiolucencies like we saw, right, there'll be a table mentioned where you they would have categorized. I mean, they would have listed the differential aspects and how you can differentiate each one from the other. For example, in case of your multilocular radiolucencies, no, you have your amyloblastoma, your odontogenic myxoma, CG, and all that, right? So you should know the differential aspect of each lesion because everything is a multilocular lesion. But how are you going to differentiate if it is an amyloblastoma or a central giant cell granuloma? So those differentiating points are given in your Wooden Ghost textbook. It is a radiology textbook. I don't know if UGs will be reading in most often, but when it comes to your competitive exams, I would definitely advise you to read the textbook. Okay, at least go through the tables. You should be familiar with the differential diagnosis terms to answer the picture based questions. Okay, so at least for that purpose you should read, discuss it with your friends, and then try to remember. Okay, so you have to like look at the picture and then you have to give the diagnosis, and sometimes they would have given a clinical scenario and all that. Sometimes it's only a picture, so you have to see that and then answer. Okay, so these are the differential diagnosis for your diffuse radio opacities. And see, whenever you are diagnosing an ideal X-ray, it should be dependent on the change in density of the X-ray, the characteristics of the margin of the lesion, the internal architecture, changes in the cortex, that is the buccal and the lingual cortex, extension of the lesion or expansion, in other words, periosteal bone reactions, and the soft tissue changes. Soft tissue changes are mostly not observed in the X-rays, but you have to correlate it with the clinical scenario if at all it is mentioned. Okay. Yep. So I think this was also, this also is useful for your MCQs. Okay. See, whenever if this feature of ghost teeth has been mentioned, think about the diagnosis of regional odontodysplasia, heart-shaped radiolucency, median anterior maxillary cyst, pear-shaped radiolucency, globular maxillary cyst, shell teeth present in type 2 dentinogenesis imperfecta, and thistle tube appearance of pulp chambers is seen in case of type 2 dentin dysplasia. Okay. So these are the features that are present in these diseases. Remember this table, so it will be easy for MCQs. Okay. Again, this one I think I've discussed it enough and more. Multilocular radiolucencies. Yeah, mixed radiolucent radiopaque lesions. So these are the differential diagnosis of mixed radiolucent and radiopaque lesions. This is going to include your cementoma, your cemento-ossifying fibroma, odontoma, CEOT, your metastatic carcinoma, chronic osteomyelitis, your Paget's disease, and fibrous dysplasia. In case of your fibrous dysplasia, it takes place in several phases. Okay, initially it will be radiolucent, then it becomes radio opaque, and the final stage only becomes mixed radiolucent and radio opaque. Okay. So again, this is another table showing the characteristic appearances. Orange peel appearance seen in case of your monostotic fibrous dysplasia, multiple punched out radiolucency seen in case of multiple myeloma, multiple punched out radiolucency with irregular borders is seen in case of eosinophilic granuloma, your fingerprint glass orange, ground glass appearance and pudi orange appearance. This is characteristic of your fibrous dysplasia, not monostotic but generally fibrous dysplasia. Then comes your driven snow appearance in case of your CEOT or your pin box tumor. Then your cotton wool appearance in case of your Paget's disease. Crew cut or heron appearance in case of sickle cell anemia or thalassemia. So these are differential diagnosis of your crew cut or heron appearance. And floating teeth in case of your carcinoma, your cherubism, and I think I have not mentioned one more, Langerhans cells histiocytosis. These three exhibit this feature of floating teeth appearance. Okay. And punched out radiolucencies, if you see, there are four differential diagnoses for it. multiple myeloma, Langerhans cell histiocytosis, metastatic carcinoma, and hyperparathyroidism. Okay, for punched out radiolucencies. And about faulty radiographs, it's a very small portion. Basically, faulty radiographs lead to loss of diagnostic information and loss of professional in the patient's time. So, it can be because of any mistake from the personal side or from the patient side, that is, any movement during the image capture, or any kind of technical error that the doctor has been doing while taking the radiograph, or it can be any kind of error with the processing part or the imaging part, or because of using an expired radiograph. In case of digital radiographs, no, there can be anything to do with the softwares. So because of that, you're going to result in the formation of faulty radiographs. So these are the four main causes, like I already mentioned: projection errors, exposure and processing errors, miscellaneous technique errors, and automatic processing errors. Okay. So when it comes to the digital imaging, these are the categories in which you're going to be present with your faulty radiographs, and errors in CT imaging and CBCT. This is just for namesake. Okay. In MCQs, they will not ask you, only for knowledge purpose. You have to just know about these. Okay. I think they might. One question was asked about foreshortening and elongation of your IOPs. Yeah. In case of foreshortening, whether the horizontal angulation is more, I mean, vertical angulation is more or less. And in case of elongation, see, always remember, whenever you increase the vertical angulation, image is going to be shortened. Whenever you decrease the vertical angulation, it is going to be elongated. Okay. It's just the opposite. Okay. Whenever the vertical angulation is increased, image is going to be foreshortened. Whenever you decrease the vertical angulation, image is going to be elongated. Okay. This was asked once, and I think cone cut they haven't asked. About your, I think mostly from your IOPA, that faulty radiographs only it was asked. Apart from that, your CT, MRI and all, nobody focus on that. Okay, try to read that part and get familiar with it. Okay, so we'll stop the class with this today. And in case you have any doubts, please feel free to let us know so we can answer and then clear your doubts. Okay, thank you so much.